Your doctor checked your blood sugar at your last appointment. They looked at your HbA1c. They reviewed your medication. They may have adjusted your dose. They sent you home with the same advice you have heard before. What they almost certainly did not check is whether your body has enough of the 3 specific vitamins that determine how well your insulin actually works at the cellular level. Not because your doctor does not care, but because standard diabetes management focuses on the glucose number as the output, not on the upstream biological requirements that determine whether insulin can do its job efficiently in the first place. Those requirements include 3 vitamins that diabetes actively depletes faster than most people can replace them through diet alone. And when any one of them runs low, blood sugar becomes harder to control in ways that no medication adjustment fully addresses, because the problem is not the medication. It is the missing raw material the system needs to function. And today, I am going to show you 3 specific vitamins that have clinical evidence behind their effects on blood sugar control, explain the precise biological mechanism behind each one, and give you the practical information you need to assess whether deficiency in any of them may be contributing to the difficulty you are having managing your glucose. Before we begin, 2 things I need to say clearly. First, everything I'm describing here is meant to complement your existing medical treatment, not replace it. Do not stop or adjust any medication based on this video. Bring this information to your physician and have the conversation with someone who has access to your complete clinical picture. Second, the numbers I'm going to cite come from peer-reviewed research. I will be specific about what the studies actually showed rather than extrapolating beyond what the evidence supports. The mechanism behind each vitamin is real and documented. The clinical effect sizes in real patients are meaningful, but not miraculous. Understanding the difference matters. The first vitamin is K2. To understand why vitamin K2 is specifically relevant to diabetes, you need to understand a protein called osteocalcin. Osteocalcin is produced by bone-forming cells and is most commonly discussed in the context of bone metabolism. But osteocalcin has a second function that most people, including many clinicians, are unaware of. When osteocalcin is activated by vitamin K2, it travels through the bloodstream to the pancreas and to muscle tissue, where it performs 2 specific tasks. In the pancreas, activated osteocalcin stimulates beta cells, the cells that produce insulin, to increase their insulin output. In muscle tissue, activated osteocalcin improves the sensitivity of cells to insulin signal, meaning the same amount of insulin produces more efficient glucose uptake. Without adequate vitamin K2, osteocalcin remains in an inactive form. The signal from bone to pancreas and muscle is not sent. Insulin production is lower than it could be. Insulin sensitivity is impaired. A study published in Diabetes Care, following more than 38,000 adults over an average of 10 years, found that higher dietary intake of vitamin K2 was associated with approximately a 20% lower risk of developing type 2 diabetes. The association was specific to K2 and was not seen with vitamin K1, which comes primarily from leafy greens and has a different biological role. The reason K2 is specifically relevant to people already managing diabetes relates to a mechanism that operates parallel to the osteocalcin pathway. Vitamin K2 is a required cofactor for the activation of proteins that regulate where calcium is deposited in the body. When K2 is adequate, these proteins direct calcium into bone and teeth, where it is structurally needed. When K2 is insufficient, calcium is more likely to deposit in arterial walls, heart valves, and soft tissue, a process called vascular calcification. People with type 2 diabetes have a risk of arterial calcification that is substantially higher than the general population. The vascular damage from chronic hyperglycemia creates a biological environment that accelerates this process. Adequate vitamin K2 directly counteracts it by maintaining the activation of the proteins that route calcium away from arterial tissue. For someone managing diabetes and aware of their cardiovascular risk, this dual mechanism, supporting insulin function through osteocalcin and protecting arterial integrity through calcium regulation, makes K2 one of the most relevant nutrients to assess. Vitamin K2 exists in two primary forms, MK4 and MK7. MK7 has a significantly longer half-life in the bloodstream, remaining active for approximately 72 hours compared to a few hours for MK4. This means MK7 maintains more consistent tissue levels with daily dosing. Clinical trials demonstrating blood sugar and cardiovascular benefits have primarily used MK7 at doses of 90 to 180 micrograms daily. The most concentrated food source of MK7 is natto, a traditional Japanese fermented soybean product that provides approximately 1,000 micrograms per 100-gram serving. For most people outside Japan, natto is not a practical daily food. More accessible sources include aged hard cheeses, such as Gouda and Edam, which provide 75 to 80 micrograms per 100 grams. Egg yolks from pasture-raised chickens, chicken liver, and goose liver also contribute meaningful amounts. One critical clinical note: vitamin K2 interacts with anticoagulant medications, including warfarin. If you are on a blood thinner, do not begin K2 supplementation without discussing it with your prescribing physician first. The interaction requires dose monitoring and adjustment. This is not a reason to avoid K2 if you need anticoagulation. It is a reason to involve your physician in the decision. I want to tell you about a patient I will call Laura. 69 years old, prediabetes with an HbA1c of 6.2. She'd recently been told her bone density was declining, and her cardiologist had noted early arterial calcification on imaging. She was not on any medication that contraindicated K2. Her diet contained almost no fermented foods, and her K2 intake from food was negligible. I asked her to add 1 to 2 tablespoons of grated Parmigiano Reggiano to her meals daily, begin consuming 2 egg yolks each morning, and supplement with 180 micrograms of MK7 taken with her largest meal of the day. Since K2 is fat-soluble and requires dietary fat for absorption. 8 months later, her HbA1c had moved to 5.7. Her follow-up imaging showed no progression of the arterial calcification. Her bone density had stabilized. I attribute that outcome to the combination of dietary changes, consistent walking, and the correction of a K2 deficiency that had been present for an unknown period. The K2 contribution was real. It was not the only factor, but it addressed a mechanism that nothing else in her management was addressing. Take K2 with your fattiest meal of the day. Fat-soluble vitamins absorb poorly without dietary fat present. The second vitamin is benfotiamine. Benfotiamine is a fat-soluble derivative of thiamine, vitamin B1. Understanding why it is more relevant to diabetes management than standard thiamine requires understanding what thiamine does and why diabetes depletes it. Thiamine is essential for glucose metabolism at the cellular level. Specifically, it is a required cofactor for the enzyme complexes that process glucose through the normal oxidative pathway inside the mitochondria. When thiamine is adequate, glucose is metabolized efficiently and cleanly. When blood glucose is chronically elevated, as it is in diabetes, glucose that cannot be efficiently processed through the normal pathway enters alternative metabolic routes. These alternative pathways produce byproducts including advanced glycation end products, sorbitol and diacylglycerol, compounds that damage blood vessel walls, nerve tissue, and kidney filtration units. These are the direct biochemical mechanisms driving diabetic neuropathy, retinopathy, and nephropathy. Research has found that people with type 2 diabetes have significantly lower blood thiamine levels than people without diabetes despite similar dietary intake. The reason is renal. Elevated blood glucose increases urinary thiamine excretion through the kidneys. The disease itself is depleting a vitamin that the disease-related metabolic stress requires in higher quantities. Here is where benfotiamine's specific advantage becomes relevant. Standard thiamine is water-soluble. Its absorption from the digestive tract is limited, and it does not penetrate cell membranes efficiently. Benfotiamine is fat-soluble. It crosses cell membranes approximately 5 times more efficiently than standard thiamine and achieves substantially higher intracellular concentrations at equivalent doses. Inside the cell, it is converted to active thiamine, where it is needed in the mitochondria and in the enzymatic pathways that process glucose. Clinical research on benfotiamine has focused specifically on diabetic neuropathy, the nerve damage that is one of the most common and debilitating complications of diabetes. A controlled trial published in Experimental and Clinical Endocrinology in Diabetes found that benfotiamine supplementation at 300 milligrams twice daily over 12 weeks significantly reduced neuropathy scores compared to placebo, including reductions in pain, burning sensations, and nerve conduction deficits. The mechanism is the reduction of the alternative glucose metabolism pathways that produce the toxic byproducts damaging nerve tissue. By ensuring adequate thiamine availability inside the nerve cell, benfotiamine redirects glucose metabolism back through the normal oxidative pathway, reducing advanced glycation end product formation and the inflammatory cascade it triggers. The same mechanism that protects nerve tissue also protects retinal blood vessels and kidney filtration units, since all 3 complication pathways share the same upstream metabolic dysfunction. I want to tell you about a patient I will call Martin, 68 years old, type 2 diabetes for 11 years. His blood sugar was reasonably controlled with medication, but he had been experiencing progressive numbness and burning in both feet for 3 years. His neurologist had confirmed peripheral neuropathy. He had been told there was little to do beyond managing the underlying diabetes. His thiamine levels were in the low normal range on standard blood testing. This is important because standard serum thiamine does not reflect intracellular thiamine status accurately. A person can have a serum thiamine level that falls within the laboratory reference range while still having significant functional thiamine insufficiency at the cellular level where it matters. Martin began benfotiamine at 150 milligrams twice daily with meals. At 6 weeks, he reported that the burning sensation at night had reduced noticeably. At 12 weeks, the numbness in his toes had improved enough that he described his feet as feeling more alive than they had in 2 years. His HbA1c, which his physician reviewed at the 12-week mark, had moved from 7.1 to 6.8%, no medication change, no significant dietary change, the correction of a functional thiamine insufficiency that standard testing had missed. The therapeutic dose range in clinical trials for diabetic neuropathy is 300 to 600 milligrams daily, typically divided into 2 doses taken with meals. Benfotiamine is remarkably well tolerated. Side effects are rare, and when they occur are generally limited to mild gastrointestinal discomfort that resolves with food. No upper limit for toxicity has been established at therapeutic doses. The practical note on food sources: benfotiamine is a synthetic compound and does not occur naturally in food. Foods rich in standard thiamine, sunflower seeds, black beans, lentils, pork, and brown rice support baseline thiamine status but cannot replicate benfotiamine's cellular penetration. If addressing diabetic neuropathy or optimizing intracellular thiamine status is the goal, supplemental benfotiamine is the appropriate approach. The third vitamin is vitamin D3. Of the 3 vitamins discussed today, vitamin D3 has the largest body of clinical evidence connecting it to diabetes and also the most complicated relationship with causation versus correlation that requires honest discussion. The observational data is consistent and striking. Multiple Clear's Throat large studies have found that people with lower blood vitamin D levels have substantially higher rates of type 2 diabetes, insulin resistance, and metabolic syndrome. A meta-analysis covering data from hundreds of thousands of participants found that people with vitamin D deficiency had a significantly higher risk of developing type 2 diabetes compared to those with adequate levels. The mechanism proposed to explain this association involves vitamin D receptors on pancreatic beta cells. Vitamin D receptor activation in beta cells has been shown in laboratory and animal studies to support insulin secretion and beta cell survival. Vitamin D also appears to have anti-inflammatory effects that reduce the chronic low-grade inflammation that worsens insulin resistance. Here is where honest scientific communication requires a nuance that most content on this topic skips. The observational data shows a consistent association between low vitamin D and worse metabolic health. The mechanistic data provides plausible explanations for why vitamin D could affect insulin function. But the randomized controlled trial data on vitamin D supplementation and blood sugar outcomes has been more mixed than the observational data would predict. The VITAL trial, one of the largest randomized trials of vitamin D supplementation, found no significant reduction in diabetes incidence in the overall population. However, subgroup analyses and other trials have found benefits specifically in people who are significantly deficient at baseline and in people with prediabetes who have not yet progressed to full diabetes. What this means practically is this. If you are significantly vitamin D deficient, correcting that deficiency is likely to produce measurable metabolic benefit. If your vitamin D levels are already adequate, supplementing beyond adequacy is unlikely to produce additional blood sugar benefit. This distinction makes testing before supplementing more important for vitamin D than for the other two vitamins discussed today. A simple blood test measuring 25-hydroxyvitamin D will tell you your current status. The clinically meaningful target for people with diabetes is generally considered to be between 40 and 60 nanograms per milliliter. Most standard laboratory reference ranges consider anything above 20 sufficient, but emerging evidence suggests that levels in the 40 to 60 range are associated with better metabolic outcomes. Deficiency, defined as levels below 20 nanograms per milliliter, is remarkably common. Research consistently finds that 40 to 50% of adults in the United States have levels below this threshold. Among people over 60 who synthesize vitamin D from sunlight less efficiently than younger adults, and among people with darker skin who require more sun exposure for equivalent synthesis, deficiency rates are substantially higher. The most important food sources of vitamin D3 are fatty fish. Salmon provides approximately 600 to 1,000 international units per 100 grams, serving depending on whether it is wild or farmed. Mackerel provides around 360 international units per 100 grams. Sardines provide approximately 270 international units. Egg yolks from chickens raised with outdoor access provide meaningfully more vitamin D than conventional eggs. Fortified dairy and plant milks typically provide 100 international units per cup. Sunlight exposure remains the most potent natural source. 15 minutes of midday sun exposure on the arms and legs in fair-skinned individuals produces approximately 1,000 international units. This declines substantially with age, darker skin pigmentation, use of sunscreen, geographic latitude, and winter months. For supplementation, D3 is the preferred form over D2, as it is more efficiently converted to the active form in the body. The appropriate supplemental dose depends on your baseline blood level and should ideally be guided by testing. A common starting dose for people with confirmed deficiency is 2,000 to 4,000 international units daily. Vitamin D is fat-soluble and absorbs best when taken with a meal containing dietary fat. The upper tolerable limit for long-term supplementation is generally considered to be 4,000 international units daily without medical supervision. Higher doses can produce toxicity through elevated blood calcium, which causes symptoms including nausea, excessive thirst, frequent urination, confusion, and in severe cases, kidney damage. Vitamin D toxicity from supplementation at standard doses is rare, but requires awareness. Regular monitoring of blood levels every 3 to 6 months while supplementing is appropriate clinical practice. Here is what these 3 vitamins share and why addressing them as a system rather than independently is the most coherent approach. Vitamin K2 supports insulin function through the osteocalcin pathway and protects the arterial and vascular tissue that diabetes is damaging through the calcium regulation pathway. It is depleted by poor dietary diversity and by the specific absence of fermented animal foods in the modern diet. Benfotiamine protects the nerve, retinal, and kidney tissue from the toxic byproducts of alternative glucose metabolism pathways and is depleted by the increased urinary excretion that elevated blood glucose drives directly. Vitamin D3 supports beta cell function and insulin sensitivity through receptor-mediated mechanisms and is depleted by insufficient sunlight exposure, age-related decline in cutaneous synthesis, and the chronic inflammatory state that accompanies insulin resistance. None of these is a substitute for glucose-lowering medication or for the dietary and lifestyle changes that form the foundation of metabolic management. What they address is the layer of biological function that medication does not reach and that dietary management alone often cannot restore when deficiency is already established. Here is where to begin this week. Request a 25-hydroxyvitamin D blood test at your next appointment. This is a routine test covered by most insurance plans and gives you the specific information needed to determine whether supplementation is appropriate and at what dose. Add 2 egg yolks and 1 to 2 tablespoons of aged hard cheese to your daily meals. These 2 additions together provide meaningful K2 from food without requiring specialty products. If you are experiencing burning, numbness, or tingling in your feet that your physician has attributed to diabetic neuropathy, discuss benfotiamine with them specifically. Ask whether a trial at 150 milligrams twice daily for 12 weeks is appropriate given your current medications and kidney function. At your next quarterly HbA1c check, share with your physician that you have been assessing your vitamin K2, thiamine, and vitamin D status. Ask whether any of these should be formally tested given your current level of control. The glucose number your doctor reviews at each appointment reflects the output of a system with many components. The medication addresses some of those components. The dietary choices you make address others. These 3 vitamins address specific biological requirements that neither medication nor diet fully reaches when deficiency is present. That is not a criticism of your care. It is an acknowledgement that metabolic disease is more complex than any single intervention can fully address. Now you understand 3 specific pieces of that complexity, and you know what to do with them. I am Dr. Kenji Sato. If this gave you a mechanistic framework that your clinical appointments have not provided, share this with someone who is managing diabetes carefully and still cannot move the number in the direction their effort deserves. I will see you in the next one.